The Opioid Crisis in America and What We Can Do About It, an enduring program presented by Great Plains Health. This enduring program disclosures are available here. One contact hour is available for nursing after viewing the program and completing the post-test and evaluation. After watching the video, please click on Take Test. The test and evaluation are combined. After passing the test, the certificate will be available to print. You will only have one opportunity to take the test and pass with an 80%. If you do not pass, notify the Education Department for assistance. Contact hours for this course are available until May 1st, 2021.
Hey. Thank you all for coming. Dr. Jason North is the Director of Pharmacy at Great Plains Health. He graduated with his Doctor of Pharmacy from Creighton University in 2000. He received his MBA from the University of Cumberland in 2011. He's worked in hospital pharmacies for the past 18 years in a variety of hospitals in Kentucky and Wyoming, and is excited to be part of the great things happening at Great.
Well, I'm excited to be able to address this topic, and in this setting will be a lot more clinical. I do a presentation like this for the hospital-wide competency, and it's a lot more entertaining in that setting because I'm trying to reach general population and a lot of people who do not work in a very clinical setting. So this is a little more exciting to be able to address some of the chemistry and physiology and things behind what we're seeing here. So let's see. But just to reiterate, 600,000 opioid-related deaths over a period of about 15, 16 years, and it is exponentially climbing. One thing that's been implicated is the increased number of prescriptions, the advertising from the drug companies, and the high prevalence and just the perception of the community that these medications are prescription, they can't be harmful, and so there's been a lot of varying factors that have led to an increased use of opioids, and consequently we've seen a lot more deaths and other tragedies related to this rise. So 115 Americans die each day from opioid overdose per the CDC. And nationally, every 25 minutes a baby is born suffering from opioid withdrawal. And we think that maybe that happens somewhere else, that is more prevalent somewhere else. But here in Lincoln County, Nebraska, we're above the state average for the number of prescriptions for opioids that are written per 100 persons that live in the county. So we have some work to do right here in our own backyard. Opioid use disorder, as defined by the let me look it up real quick. DSM-5 lists 11 symptoms that define an opioid use disorder. And so just taking larger amounts or duration than intended, a persistent desire, the time that is spent by an individual searching for or looking for ways to obtain medications, the craving effect first thing in the morning, that's what you're looking for, and failure in all of the major aspects of life that are brought on by addiction. The two at the bottom, tolerance and withdrawal, even though those are included as part of this syndrome, those can also be related to just use of the medication without reaching the point of addiction. There can be a physiological dependence develop. So severity is determined by at least 6 or more symptoms. Addiction versus pain management, that's where our role comes into play, because so often in the ER, at the retail pharmacy, up on the floor, it's very easy to fall into the trap of thinking, well, that's just a drug-seeking patient. They're not really in pain. They just keep pushing that nurse call button, but they don't really mean it. they're just an addict. Actually, we need to be able to define the difference between addiction and pain management, and we need to recognize that we're here to treat their pain. And opioids are not the silver bullet. They don't cure everything. We need to look at a multi-modal approach. So we'll talk about that a little more as we go. But there's definitely a physical dependence and a withdrawal that is built in to the receptor sites that are upregulated through the use of opioids, and a tolerance develops. So actually this effect of tolerance is one of the ways that we eventually catch healthcare workers who have a problem. Because the good thing is you might be able to steal one Percocet today, you might be able to swipe dilaudid injection next week, but pretty soon it's handfuls of medication that need to be taken to get the same effect. And unfortunately, along that pathway, patients are harmed. Patients are not treated for pain because healthcare workers are taking those doses instead, and possibly adulterating and contaminating containers and packaging that is later used for the patient. And so I've seen a lot of things in 18 years, different methods of hiding addiction and the resultant problems that develops. I've worked with an anesthesiologist who was a fentanyl addict. I've worked with a pharmacist who was a fentanyl addict. Always brilliant people, and yet there is no demographic immune from this problem. Multiple nurses have fallen into the trap of the ease and accessibility of opioid medications. So that's something that we need to really be able to guard against and to be aware of with our coworkers, and to watch for signs and symptoms and problems that can be addressed, and you're actually helping that person as well as protecting your patients. So never be afraid to share that information. Addiction is a behavioral maladaptation with the 4 C's: a loss of control, compulsive use, continued use, and craving. So those 11 symptoms are condensed into the 4 C's, and that kind of sets apart the patient that we need to do pain management on versus the patient that we need to look at possibly some tapering, some recovery, and some multimodal treatment to be able to continue to do pain management and back them away from that ledge of addiction. This is the most fascinating study to me, and we'll see in a little bit in my presentation that this has led to some regulatory and legal changes in prescribing habits. So this is a day's supply of first opioid prescription. They studied 1.3 million patients. This was reported by the CDC and performed by University of Arkansas. They took insurance information on over 13 million patients. They then randomly selected 1.3 million patients out of that pool and looked at anybody who had never had opioids for cancer or a chronic pain treatment therapy, and patients who had never been treated for opioid addiction. They took those 1.3 million patients, they looked at the day's supply of that first opioid prescription that the patient received, and then they looked 1 year out and 3 years out to see who was still taking an opioid after that first prescription. Interestingly, on the very first day, 1 day's worth of opioids, there's a 6% chance that that patient would still be taking opioids a year later. And that may be because they developed an addiction, it may be because of a trauma that they were in and had chronic pain after that. But 6% of patients on day 1 And you think, how many times have you been to the dentist or had a family member go to the dentist or go to the ER, and they're given like a 30-day supply for a very minor acute type of pain. With a 30-day prescription, when we look at 1 year out, there's a probability of almost 30 to 35% of patients will still be on that opioid a year later. After 5 days, there's about a 13 to 15% chance that the patient will still be taking an opioid a year later. So this is where the legislators have started to target. Less than 7 days is where we want that first prescription to be, because after that you can see it just skyrockets the risk for that patient to develop addiction. So one thing that we need to look at in formulating our plan to reduce the risk for addiction, to reduce the risk for development of other comorbidities related to addiction, is also when we are assessing for pain, we need to assess for sedation as well. And the Placebo opioid-induced sedation scale is one method that's used to make sure that your patient isn't so somnolent that they can't ask for pain medication themselves. And we've seen also with PCAs, patient-controlled analgesia pumps, post-op, that sometimes we develop respiratory depression because the patient can't push the button and you have a continuous dose running. At one hospital I was at, we had a post-op bariatric surgery patient who, if the mother had not been sitting there, she would have died because she went into respiratory depression. She had not been to a sleep lab. She didn't know that she had sleep apnea, but as she was resting there comfortably, she just stopped breathing. And the patient's mother and the patient's child were both there and noticed that she's not moving, and called the code blue, and we got some Narcan on board, and we changed our hospital policy after that, that there would no longer be a continuous rate on a PCA. If the patient was not awake enough to push the button themselves, they did not have that continuous rate because of the increased risk. What we want to be able to approach our pain management with is a multimodal attack. There are so many different neurotransmitters, so many different receptors, so many different pathways that are involved in pain that it's no longer just a one pill treats all type of methodology anymore. We want to look at, we've always known that there were multiple receptor sites for opioids. The mu receptor site is what blocks pain transmission. And that's the one that endogenous endorphins immediately focus on. So that's where if you get hurt, you get that rush of endorphins, and it immediately attacks those mu receptors to stop the pain transmission up the central nervous system. Once it hits the brain, the kappa receptors are there to pick up the euphoric effect of that. And for those who run or exercise, and Doris can tell us about the runner's high, you hit that block, and then all of a sudden it's like, wow, I guess I could run another 26 miles. This is no problem now. So that once those kappa receptors are hit, that's where you get the addictive potency of your opioids. GABA is the receptor that is kind of an inhibitory or depressant type of receptor. This is where your propofol, alcohol, gabapentin, all of those work, and that reduces neuropathic pain, which is another type of pathway that we need to explore for multimodal therapy. The opposite of that is the NMDA receptor, and this is an excitatory receptor, that's also used for learning and memory and concentration. And when those NMDA receptors are destroyed by heroin or another semi-synthetic opioid, then it's kind of interesting that destruction of brain cells, that really does destroy brain cells, does not inhibit the person from seeking that drug even more. So it's a sad statement that continues to destroy the brain pathways, and it actually leads to apoptosis of those neurons, because they stay in an excited state for so long due to the drug that it just wears out the cell and destroys it. Substance P is a small protein that's ubiquitous throughout our body, and it is the protein messenger when there's some noxious stimuli or nociceptive pain. It immediately sends out inflammatory markers and tells the nervous system to start releasing endogenous endorphins again, and trying to tell the brain where that pain is located. Dopamine, once everything hits the brain, then the brain wants to be able to minimize the pain, and so it releases another chemical called dopamine, and we frequently use this to help control blood pressure. We give it IV for that, but it's the chemical that tells us to go back to that same situation or same drug, because it ultimately resulted in a pleasurable experience. And it's interesting that I have a friend who's a nurse. Her daughter is 15 years old. She's been in a psychiatric ward for a couple of months because she cuts herself. Well, why would someone continue to cut themselves? Because it releases all those neurotransmitters that send eventually to the brain that messenger of pleasure. And so even though somebody does something that is personally detrimental, they continue to go back to it because in the end they think they're getting a positive feedback, positive response from that. It's horribly tragic, and it's a very difficult cycle to break. Be able to learn a new way to release that dopamine in more constructive, positive activities. So epinephrine, of course, is our fight or flight. Norepi and epi give us that sympathetic response, and also vasoconstriction around the site of the pain, because it wants to decrease the blood flow there. And then serotonin is interesting. There's over a dozen different receptor sites for serotonin. It's like the drug that does everything. It's an antidepressant, anti-nausea on the chemoreceptor trigger zone in the brain, and it also helps with migraine pain as well. So it's kind of a universal, does everything type of neurotransmitter. So as we kind of look at the afferent and efferent neurons, that's where all the activity is taking place. That's where all these tiny little receptors are located, and that's where small changes in electrolytes and proteins set off an entire cascade of effects in our brain to deal with pain. So see that in the nociceptors, that's where we get our substance P, and that lets us know that, hey, you're leaning on something hot or sharp, and sends that pain message to the brain. We've got our opioid receptors here, the kappa one that leads to the euphoria, the mu that leads to the pain relief, Sigma is related to some other psychotropes. That's a site that they affect too. It's not so much opioid related. And that sets up the central nervous system. Again, just another picture of our neurons and the substance P peptide that's also there, the prostaglandins, where you see the NSAIDs working to decrease that inflammatory response. And also, it's interesting that opioids occasionally will produce a hyperalgesia. So even though you're treating pain and you think you've reached that threshold, paradoxically, some patients will experience an increase in sensitivity to pain, especially noxious stimuli. There's several processes that they're trying to figure out that lead to that in the periphery, and an increased sensitivity to nociceptive pain. So these are the different pathways, different approaches to pain management, and we should be able to discuss with our patients about their pain. The HCAP scores now have changed their questioning about pain. It's no longer did we treat it, titrate your pain to 0. It's did we talk to you about your pain and about your pain management, and expect that when you've had bones cut and different things done, an open surgical site, you are going to experience pain. Welcome to life. That's the reality, and we need our patients to be able to understand that. But they also need to be able to understand that there's multiple ways to treat that pain, depending on the source. So just looking at inflammatory response, steroids, non-steroidal anti-inflammatories, ibuprofen, ketorolac are ways to treat that inflammatory response. And typically after a surgery or a trauma, you want to treat every pathway that you can as aggressively as you can for the shortest amount of time that you can. And that allows the body to heal much faster because it doesn't get overwhelmed with inflammation and substance P and the cytokines and everything that leads to pain and fever and swelling and all of the things that kind of get in the way of your body being able to repair those tissues. So, never push the right button. Nociceptive is like a surgical cut. It's the peripheral pain, and amazingly it can be treated with an ice pack. A cold pack is very good at reducing inflammation, reducing the movement of those peptides at that site, and allows the body to heal from right there where the wound is at. Very effective when you've got, for an example, one of our anesthesiologists here at the hospital talked about a motor vehicle accident patient that came in. His kidney was lacerated, and of course the skin above it was broken. And how do you treat that? You can't necessarily give an NSAID because you don't want to decrease blood flow to the kidney that's already suffering trauma. You don't want to give an opioid because, well, they had actually given opioids and the patient wasn't responding to the opioids because the pain was organ related. It didn't have a clear pathway with the central nervous system. So finally the doctor just got an ice pack, and the guy laid on it, and suddenly his pain went from an 11 out of 10 to a 1 or a 0 because it was numbing that area and making it feel better. Treating the nociceptive pain. Lidocaine, other topical anesthetics are used for that same purpose. Opioids are great for muscle neuropathic pain. Muscle relaxers could be used as an adjunct without the opioid effect. and yet allow those muscles, it works more on the electrolyte balance in the muscles to kind of decrease the tetany and allow the muscle to relax. One thing that our anesthesiologists here at the hospital are very good at are regional and neuraxial blocks. So by injecting some bupivacaine into the epidural space or around a regional block, they're able to prevent the patient from having to use an opioid, and yet they still have a block of pain transmission from that limb or that site. And there are so many multiple ways and places where they can place those blocks. It's really quite amazing the work that can be done there. So pretty impressed with our anesthesiologists here. They do a fantastic job, and they're very knowledgeable about ways to help reduce opioid use and provide that patient care and pain relief. Of course, GABA can be used to prevent neuropathic pain, and so our pregabalin and gabapentin medications act on that pathway to help reduce that peripheral nerve pain response. And sleep aids. One of the best medications I've ever found is a 14-hour nap. Seems to cure just about everything. So helping your patient get sleep allows the body to heal itself. Acute versus chronic pain. There's a lot of studies on patients who have been on chronic opioids. There's a pain specialist here in town that's affiliated with the hospital, and she's doing a lot of research with using ketamine to actually decrease the regulators, the NMDA upregulation and opioid receptor site upregulation, and it kind of causes a reset of those receptors so that the patient no longer has that craving or that high dose of opioids that's necessary to reach that threshold for pain management again. So it's kind of a reboot of the system, and it's kind of interesting to see that because it's a drug that's been around for a long time, and so there's not a lot of research for using it for this purpose. It's been an anesthetic for a long time, and now we're using it at sub-anesthetic doses to produce a whole new way to eliminate opioid addiction. And it's helping with these chronic pain patients. Again, with our acute pain management, we want to be aggressive, we want to cover as many pathways as possible, and we want to do it in the shortest amount of time possible. Our orthopedic surgeons have a cocktail of different chemicals that they request for every surgery, hip and knee, to be able to inject around that site, and it contains multiple medications that hit these pathways. It contains ketorolac and morphine and clonidine, and there's one other medication in there. But that has been so effective that when we went live with Epic that first day, we had 3 patients, and the nursing staff documented 0 pain on those patients within the first 12 hours after surgery. And I don't think it was because the patient was in a comatose state. I think they certainly came out of recovery okay. But it was because our orthopedic order set addresses all of those pathways of pain in a very efficient manner. One thing that nursing is looking at providing for our patients now is something called a comfort menu. And this is something that we're in the process of rolling out. But it allows your patients to look over a list of things that correlate to these different pathways of pain and be able to request things like a crossword puzzle. It's kind of interesting in the cancer center. What do you see when you go in the cancer center? There's puzzles to work on, there's magazines, there's music, there's a TV. There's all kinds of different things to kind of take your mind off the pain. Well, that truly is a pathway of pain. Take your mind off of it. And there's different things that can be done. Just getting up, getting the patient out of bed so they're not thinking about the pain. They're not prolonging the pain by laying on whatever joint is in pain. Especially ortho patients are up and moving right away so that the scar tissue doesn't set up in there, and so that those pain medications have a chance to work on all those different pathways. Tapering opioids is another area that is gaining increasing popularity. Looking at how pain medications are prescribed, just like steroids now, there's a decreasing dose with each day, so that by day 7 or by day 5, the patient is off of the opioids, so that we don't get that increased risk of addiction 1 year out, 3 years out from that initial prescription. So things that are being done is, first of all, is to convert things to a morphine equivalent, because that drug has been around for quite a while, and it's very easy to relate the equianalgesic dose back to morphine as the gold standard. So you can tell how many milligrams per day or per week a patient is taking in those morphine equivalents, and then you can look at tapering that down by a certain percentage. So you want to be able to talk to the patient about that and tell them that tapering is a safety issue. We care about our patients. We don't want them to become addicted, but we do want to treat their pain and get them healed as quickly as possible. Tapering is based on the type of medication that's used, a long-acting versus a short-acting medication. If multiple drugs are involved, you taper one at a time. So in rehab, you start with the heroin. You get them off of that, or the OxyContin. And then maybe the benzodiazepines or anything else that they may be taking. The very last thing that they attempt to wean a patient off of is nicotine. So let them smoke all they want. They're not shooting up with anything. We're good to go for a little while. And you just take one step at a time and one addiction at a time to allow the body to recover. You know, the brain has to recover from the effects of that. There's a lot of patient contracts that are put into place, a set of beginning date and ending date targets to meet along the way, so that the patient can mark those milestones to recovery as well. And behavioral supports, the counseling, the counting their pills, doing drug urine screens, the accountability factor is a part of that recovery process. So 5 to 10 to 15% weekly to taper their doses down. And then once you reach half of that dose, and we see this now in our pain management clinic, the ketamine has been used to help downregulate those receptors, bring the patient back down to a manageable state. And from there, we don't completely take away all the opioids, but we're down in a more manageable state. The patient's able to go back to work, be able to relate to their family better, be able to attend class, and be able to recover socially and emotionally, as well as physically and physiologically. So there's a lot of adjuvant medications that can be used to help maintain that state of recovery, as well as treat the side effects from it as well. Methadone, of course, has a long half-life. It's a very long tapering process. Suboxone has become quite popular for management of opioid withdrawal and allow a patient to live a fairly normal life now without having to go to the methadone clinic every day and the stigma that's attached to that. So a lot of new formulations of medications are coming out to help prevent tampering and misuse, as well as provide therapy for recovery. Let's see. So just as an example, on post-op day 1, patient's going to get an opioid combination with acetaminophen routinely every 6 hours, because again, we want to be aggressive and we want to treat fast and furious and get that pain under control and allow the body to heal. On day 2, possibly later in their therapy, but we start to switch out and just use a dose of Tylenol or a dose of ibuprofen instead of that Percocet or Norco. And last of all, that one dose at bedtime to help the patient sleep, because again, that's my favorite medication, sleep and water, and chocolate maybe too. But that allows the patient to be able to sleep and recover and yet be alert enough during the day. So that's an example of how tapering can be used with a substitute medication during those doses so that you're staying ahead of the pain and have a routine scheduled pain regimen. Non-opioid acute pain management. One of the new things is an opioid-free ER. Well, that's like a drug-free workplace in the pharmacy. It just doesn't quite work that way. We have to keep some opioids available, of course, and the goal now is to look at common ailments and pains that people present with and find alternative methods to treat those pain symptoms with through, again, those different routes of pain management. So migraine, renal colic, osteoarthritis, hyperalgesia, fractures even, can be treated without opioids, which I thought was pretty amazing, because if I come in with a broken leg, first thing I would suspect that they would give me is a big shot of morphine. They can actually do a regional block. Something, bupivacaine, lidocaine, can be just as effective when placed appropriately to block that pain transmission, allow the patient to calm down, get the x-rays needed, and get the bones set. So very interesting, the different methods that are being explored now to reduce opioids in the ER. This has also led to a lot of regulatory changes, and part of that is the prescription drug monitoring program. Almost every state now, I believe, participates in a prescription drug monitoring program. Ideally, eventually that will be linked nationwide. When I was in Kentucky, there were more Kentucky license plates at the pain clinics in Florida, and then there were Kentucky license plates left in the state of Kentucky at times. So everybody went down there, got their MRI in the back of a U-Haul truck in the Walmart parking lot, and then picked up their pain med prescription, got that filled either in Kentucky or Florida, and came home with armloads of pills, and usually walked in with wads of cash to pay for it, and it was no problem at all when you live that entire lifestyle. However, the prescription drug monitoring program has helped curb that quite a bit, because now prescribers have access to see what their patient has received already and what the history of their opioid use has been is readily available now online for prescribers and pharmacists to see. So as nursing staff, it's pretty important to be able to know that information has been looked at and referenced when you look at their home medication list. And the pharmacy technician that we have stationed in the ER is able to access PDMP and make sure that that is reviewed when the home medication list is compiled. Since January 1st, 2018, the PDMP now requires all medications, not just controlled substances, to be logged in this system. So now home medication lists are extremely easy to get to, because you know exactly what the patient has picked up at the pharmacy and when and how much, and what the prescribing directions are for those medications. So that's been a great help, and as those connect and network across multiple states, it makes it easier to track those out-of-state prescriptions and trips to Florida or Colorado. There's also a new Joint Commission standard for pain management, and that has changed our whole outlook on what we need to do for the patient. Pain management stewardship now is as important as antimicrobial stewardship, and making sure that our patients are treated and not iatrogenically induced to become addicts. So we'll explore that a little bit more. And then, of course, our HCAHPS questions for customer satisfaction and helping them understand that they are not to expect a zero level of pain, but a baseline of pain or a baseline of pain control. Pediatric opioid prescriptions, a new law was just passed April 4th, 2018 in Nebraska related to prescribing opioids for anyone under the age of 19. So our prescription drug monitoring program decreases doctor shopping. It allows our ER to know if the patient's already been to 3 other hospitals that evening and what they've picked up, and tracks all prescriptions. And I imagine that this will become more important in our prescribers' habits, and also become more of an accountability issue too, because everything is much more transparent. So you know which physician in a community is the one to go to, I guess, for all the pain meds, or who is part of the problem and not part of the solution, I guess. But we all need to be part of the solution. So our Joint Commission standards, I thought it would fall under medication management because it's med-related, but it actually falls under the leadership portion of the Joint Commission standards, which I think is invaluable, because that means the CEO down is responsible for management of pain and reduction of opioid abuse in our facility. And we're very lucky to have that support from the highest levels to be able to make this a reality for our patients. So we want to look at non-pharmacologic approaches. Again, that comes back to that comfort menu. And everything is patient-centered. What will help our patient the most? Pediatric opioid prescriptions. So I just wanted to, this would be something that the nurse may very well have to counsel the patient on. So any patient that's under 19 years of age, if this is their first opioid prescription, then the practitioner, the doctor, the nurse, pharmacist, somebody needs to sit down with that patient and the legal guardian and explain to them these principles. So the risks of addiction and overdose associated with a controlled substance or opiate being prescribed, including but not limited to controlled substances and opiates, are highly addictive even when taken as prescribed. Do you remember the percentage of patients after day 1 that may still be taking an opioid a year later? 6% of patients can become addicted on day 1. So it's very, very important, especially in our pediatric population, to make sure that that's available and addressed. There is a risk of developing a physical or psychological dependence on the controlled substance or opiate. And taking more controlled substances or opiates than prescribed, or mixing sedatives, benzodiazepines, or alcohol with controlled substances or opiates, can result in fatal respiratory depression. I think if I had heard all of this when my son was getting Demerol at the dental office, I think I would have thought a little more deeply about this. But it came in Nestle Quick strawberry syrup, so it must have been safe and good, you know, because the injection was mixed. Pediatric dose. The reasons why the prescription is necessary and alternative treatments that may be available. Yes, you're having your wisdom teeth out. No, you do not need a 30-day prescription of Norco for your wisdom teeth. Try some ice, try some ibuprofen for the inflammation. We're treating inflammation with that type of scenario. So there are alternatives. This will need to be discussed with the patient on the first prescription, and before a third prescription can be prescribed for that patient. It will need to be documented in a chart. Every surveyor of any kind in Nebraska will now be looking for this documentation. And I imagine the fines will be pretty heavy when it's not in the chart. So again, just a reiteration of how important this is. The day's supply is such an important factor in what we see a year or 3 years down the road. In summary, we've covered addiction versus pain management, assessment of sedation as well as pain score, and then that multimodal approach based on the different types of receptors that are part of that pain pathway process. And then the comfort menu that allows us to kind of get our patients a little bit happier, a little more cheerful, get their minds off of the pain and why they're here, and that the hospital doesn't have to be a big scary place. And it's a fun place to come and do jigsaw puzzles and crossword. So I don't know. And then tapering opioids, opportunities to substitute medications that continue to treat the pain in a scheduled regimen, but treat it in a little bit different pathway to avoid the opioid overdose. And then the multiple regulatory updates that are surely just to increase. I think we're just seeing the beginning of some of these regulations that will affect how we treat pain. Thank you for your time.
Jason, I have a question.
Yes.
So this prescription drug monitoring program, does that cover meds that are taken cash as well, or is that just meds that go through insurance?
At this point, it's only medications that go through insurance. And so that is a big loophole to the process, because we know that a lot of opioid prescriptions picked up in the retail setting are purchased with cash.
Also, I have another question. I have 3 questions. So, Tylenol and ibuprofen. Have you heard, and I don't know where I read it, I probably read it.
I'm
So,
just asking that
2
myself.
Tylenol and 2 ibuprofen taken together works better than an
It's
opioid.
more powerful than
Does that make sense to you?
opioid.
Well, we are treating multiple pathways when you use the 2 medications together. And remember, the opioid is only treating the one pathway. It's only blocking the delivery of that pain message to the central nervous system. When you use an NSAID, then you're decreasing inflammation, you're decreasing substance P, you're decreasing the nociceptive pain, and then the acetaminophen also helps decrease the cytokines that cause fever or heat at the site of the wound. So you've got multiple pathways there, and so that's why that's a good adjunct combination to use, especially in that regimen where you're trying to taper the opioid off and you utilize those other medications. You're actually treating more pathways of pain, and we'll probably see a greater reduction in pain overall. So
I know, like, my husband had migraine without an insurance, so I gave him that, and his pain went away, like, which is pretty rare for his migraines to just go away like that, so I was pretty impressed with that.
heck of a lot cheaper than sumatriptan.
Yes, well, insurance. So, and then my third question is, and this is just my personal information, the HCAP scores, do you think that the pay for performance had anything to do with the opioid crisis? Do you think that the doctors are giving out more opioids because they want better reviews so that they get paid?
Yeah, I don't want to peg anybody as the bad guy in this, because no snowflake in an avalanche thinks that they are responsible for everything. However, the government released that requirement that we treat pain, we titrate to 0, and so it did give us kind of a blank check as healthcare providers to think, I'm doing the best thing for my patient. I'm loading them up on the narcotics because I want to make sure that either they're too gorked out to tell me that they're in pain, or we actually have treated that threshold of pain. So yeah, I think HCAP scores, I think that's why Joint Commission is backpedaling now so fast and coming out with new standards, because they're recognizing that was a mistake in the first place. That it should have been more of a collaborative, patient-centered care, and involving the patient in the development of their own pain management regimen as well. So, yeah, very, very good question. Any other questions or comments?
I have a question about like the mail order. So mail order, you can get 3 months at a time. Is that going to be changed? Because I know with pain medications, you can get a 3-month supply.
Oh, yeah.
I mean, they run out
Comes in
a little early.
Mayonnaise jug.
Well, the VA used to send my dad 6 months at a time, so he would get like 6 bottles at a time, and they would just automatically send them.
Yeah.
So he had bottles.
Payments?
Hydrocodone. Yeah.
I saw that on the Indian reservation in Wyoming too. It didn't matter. You got all of your prescriptions every month, whether you took any of them or not.
Yeah.
And generally patients would come in with a cooler of medications because they had 3 years worth of medications in there, of which they were only taking 2. And so, yeah, I think we will see more and more regulations on this. And that, unfortunately, is also leading to an increase in heroin usage.
Yeah, that's what I
And
was
fentanyl purchased from across the ocean because that addictive behavior is not going to be stopped just because you're cutting yourself, for example, or just because you're doing something detrimental to yourself does not overcome that dopamine release at the end. And so, unfortunately, we will continue to see patients come into our ER with multi-polypharmacy effects of an overdose, because you don't just get heroin, you don't just get fentanyl, you get all the other things that get mixed in with it to give a higher high for less output on the dealer's end. So it's all economics in the world of illegal drugs as well. So interesting.
I have a question on that PDMP.
Yes.
So who has access to that? Because you said the pharmacy tech and ER has access to that.
As an agent of either a pharmacist or a physician, someone else can be given access to get into that, but you have to be, it has to be a collaborative agreement under one of those providers, a pharmacist or a physician. So law enforcement can't access it. The judge can't get into the file. It has to be through healthcare because they don't want it to be a punitive system. They want it to be a helpful system to decrease this epidemic. So that's the purpose behind it right now. Anything else?
You have now finished the program on opioid crisis. If you would like a copy of the PowerPoint or reference list, please contact Jill Stevenson at stevensonj@gphealth.org or 308-568-8606. Please proceed to take the combined test and evaluation. After passing with an 80%, you will be able to print your certificate. Any issues, please contact Jill Stevenson.